Hi, I'm Heather Orsted, and I'm welcoming you to the Pressure Ulcer Awareness and Prevention Program. The objective of the following sessions will be you will recognize the impact of the Pressure Ulcer Awareness and Prevention Program, determine how this program will benefit your healthcare setting, and perform the steps involved in implementing and evaluating the program. Our motto is pressure ulcer prevention begins with admission. First of all, we have to admit in healthcare that we have a big problem with pressure ulcers in all clinical settings. The second part of that is patients, clients, and residents all need to be evaluated on admission for their risk for pressure ulcer prevention and a care plan generated to help prevent pressure ulcers. Our first session will revolve around reviewing the rationale for the development of the Pressure Ulcer Awareness and Prevention Program, explore the developmental process, and discuss the impact of the program. So what was the problem? Well, back in 2003, we commissioned Woodbury and Houghton to look at the extent of pressure ulcers in Canada, and the results were quite shocking. We discovered 25% in acute care, 30% in non-acute care, 22% in mixed healthcare settings, for example, a facility that might have acute and long-term care, and 15% in the community. The mean overall prevalence was 26%. So this meant 1 in 4 people in healthcare settings had a pressure ulcer. Now this included pressure ulcers from stage 1 all the way to stage 4 using the National Pressure Ulcer Advisory Panel recommendations. So we decided to fund, create, and pilot a quality improvement program that would increase the awareness about pressure ulcer prevention, improve current clinical practice related to the prevention of pressure ulcers, improve the management involvement and policies to support the changes in clinical practice, and reduce the occurrence of pressure ulcers. We used a strong educational model to build this program. Kitson states that the evidence needs to be scientifically robust, and we based our program on the Registered Nursing RNAO, Registered Nursing Association of Ontario's guidelines for the prevention of pressure ulcers. The context needs to be receptive to change. I just mentioned in the last slide that we really needed management support in order to ensure that the education and the resources were supplied to the site champions who were leading the program. And then the change process needs to be appropriately facilitated. We train local site champions to help with the implementation of this program. What makes this program different is that externally it is generic and evidence-based, as I mentioned, based on RNAO best practice guidelines. It's portable, adaptable, flexible, and transformable, meaning it can be applied to your clinical setting. Management commitment, we have your management sign on the dotted line. If you are management, you have committed to ensuring the efficient and effective delivery of this program. Ongoing support through a national team leader who is there to help guide you through the implementation, evaluation, and even the sustainable aspect of this program. A champion network, online discussion forum, and conference calls. Also, we layer the education that you're going to be delivering. You will have posters and buttons and badges and many different types of enablers to help your staff explore and discover the importance of pressure ulcer prevention. Internally, pressure ulcer risk assessment needs to be on admission. That will be a practice change. On admission, patients will be assessed. Then a customized action plan will be created based on that risk. High-risk rounds and care reviews will ensure that best practice are implemented. We encourage involvement of everyone in your facility, residents, families, companions, and all caregivers. And of course, ongoing evaluation of the program through identified outcome measures. We ask nothing more than best practice delivered consistently. We have many programs running out of the Pressure Ulcer Awareness Program. We have the pilot that ran successfully. We have our PUAP program is both nationally here in Canada and outside of Canada as well. We have a long-term care project going on in the province of Ontario. We have a collaborative program going on in Ontario as well, and we are looking forward to pressure-free zones in which all facilities within a certain location are all running the Pressure Ulcer Awareness and Prevention Program, ensuring that everyone is delivering best practice. We involve everyone, as I mentioned, from the kickoff event to the educational event. Residents, families, clinicians, and managers are all involved and eager to make pressure ulcer prevention a priority. Have we made a difference? We have shifted culture. We want you to join our team. We know that we can make a difference in the numbers of pressure ulcers in your facility. In this table here, you notice that in 2003, pressure ulcers were 24.7. In 2004, they received a lot of pressure redistribution surfaces, yet in 2005, the prevalence had hardly changed at all. It was not until the Pressure Ulcer Awareness and Prevention Program was brought in and staff were educated that the numbers actually dropped and the pressure ulcers were reduced. We also know that early recognition of stage 1 pressure ulcers is very important. So don't be surprised if your numbers actually go up rather than go down as staff recognize what redness really can mean. Also, stage 2, 3, and 4 pressure ulcers decreased, and documentation was much better. You see here in May, 30% were documenting on care plan changes based on risk. By September, 66% were documenting. That is a change in practice that is very positive. Also, you will be saving money. This example here shows a 100-bed facility. If they had a 35% reduction in their prevalence, they would see cost savings as indicated here. So for an uncomplicated ulcer, it could be $239,000 a year to a complicated stage 4 ulcer, which is in the millions. Also, cost savings can be recognized in the area of wound care supplies. One facility said that purchasing contacted them and said, "What's happening? Our cost for dressing supplies has gone from $90,000 to $55,000. Big savings here. Increased use of support surfaces and positioning aids. Some facilities said only 1 pillow per patient, and all of a sudden they realized how important it was to get those pillows used in positioning patients in positive positions to avoid pressure ulcers. Increased purchase and availability of pressure redistribution aids. Improvement in nutrition programs. Increased discussion around risks and prevention. We have seen reduced suffering, reduced hospital times, reduced workloads related to dressing changes. Long-term care homes can demonstrate a level of quality, and if these quality indicators are made public, facilities that have prevention programs may be rated more favorably.